just because there's been quite a few patients today. I'm just going to make sure that you can actually see it. So bear with me a couple of seconds, because ideally I would like to show that at the same time. Let's see, come on. It does take some time to get used to, well, to say that the live is actually on. I wish they could do a quicker way. Okay. It's coming up now. Okay, right. So I'm going to go through pain relief, and I will go through questions as I go along. So if I don't answer any questions, bear with me a bit. But the reason I'm going through this, so the pain ladder and pain relief, is because today in my clinic, and usually pain relief is one of the most common reasons as to why I have to ring a patient. And basically, a lot of patients aren't aware of the risks of pain relief, but also not aware of the reasons as to how we can prevent the use of pain relief going forward, which is a big thing for me. So I've done this thing. I mean, I need to actually double check whether this is still what we go off, but it's called the WHO pain ladder. And basically, it was what we were told in university and early medical practice, is that when you are starting pain relief, you start off with the weakest type, which is paracetamol. You go then to NSAIDs, which stand for non-steroidal anti-inflammatory drugs. These are your ibuprofen, your naproxen, diclofenac, all these things. If that is inadequate, then we go to weak opioids, which are your codeines and your tramadol. And then if they don't work, you will go up to your strong opioids, which are your fentanyl, your morphine, your buprenorphine. So that is where that is at the top. So you've got morphine. This is quite hard to write from here. Morphine, buprenorphine, and you've got fentanyl. Obviously, you have a lot more things up there. You can have pethidine. I'm not going to go into that, but that's the generic way. And you go up if pain is not managed. And then obviously, if in an ideal situation, if your pain is managed and the reason as to why you were in pain was or has been resolved, then ideally you should come back down a ladder. However, this is the step that never normally happens. So as you can see, that is the pain ladder. And a lot of people actually don't understand. So I'm going to go through a few of the things. So the biggest cause for people going on to pain relief in the first place, and this is where I always start, is I'm just making sure that everything is in place there. But basically the number one reason as to why patients are started on pain relief is due to lower back pain. Now, lower back pain, I'm going to write it down, or knee pain. And these are the most common. And when you actually look at any guideline, any evidence or advice based around how do we manage lower back pain in particular, it usually is self-limiting within 12 weeks. Obviously, that is a long time for a lot of people. But from my experience, it normally comes from a couple of things. And this is actually quite difficult to write, especially with this bottom bit. Actually, bear with me a second. I'm going to remove it so that there is less of a hindrance to it. I've got to unscrew this. Okay, that bit's come off. Just one more. I can see a few questions, so don't worry. I will come through to them once I've done like a little section on each. Right, so yeah, 12 weeks is the usual course length for anyone experiencing low back pain. Usually, I will say it due to high BMI / lack of exercise. That is the most common that I would say. And then obviously you do get the odd actual trauma, which is anything to do with manual labor jobs. So a lot of builders and people who lift heavy objects on a daily basis due to improper form, that's a big thing. But I would say the biggest thing is the fact that a lot of people have a high BMI or a lack of exercise, because the majority of people within the UK, even me, and I was discussing it today, have an overall low basal activity because of our jobs, the way that the the world is sort of geared up. So with regards to lower back pain, how should you treat it? You should always try and stay active. And this is the same with a lot of musculoskeletal pain. So that's MSK pain. That is anything to do with like knees and back, whatever you can think of when it comes to joints. And the biggest thing is you want to try and strengthen the muscles around any of these joints. So with the back, why have you got lower back pain? Is it because you have weak hamstrings, weak glutes, weak abdominal muscles? All them things do precipitate to you then putting too much pressure within certain joints, which then leads to certain pain. So that is the first thing I would advise, is strengthen your muscles, do activity, increase your baseline activity. When you are experiencing acute lower back pain, you will not be able to do a lot of things. So bear in mind, I'm not telling people to go to the gym and do all these other things. Obviously, listen to your body. But once you start to recover, you should then be doing a lot of physio-based exercises, and you will get the greatest outcomes from that. But no more than likely, you will be put onto pain relief, and that is probably more due to the patients because they want some sort of quick relief from it. So the first one that always comes up is paracetamol. Now, depending on where you are watching this from, the Americans will call it acetaminophen, I think. Anyway, I'm not even going to spell it, but acetaminophen is how the Americans will pronounce paracetamol. How does it work? There's actually no conclusive way in which the mechanism of action has been established for paracetamol. Again, before I go into all these things, the same with all my videos on YouTube and wherever, it is for informational purposes only. It's not medical advice. But for pain relief, you will have, depending on weight, it'll be 500 to 1000 milligrams 4 times a day. So you will have no more than 4 grams in 24 hours. So that is a big thing, because one of the most common presentations that I used to see within A&E, with my job, was that a lot of people come in with acute overdose of paracetamol, and that might have been a staggered overdose, meaning that they don't just have it all in one go. It might be 6 to 10 grams throughout a 24-hour period, and then you still got to treat it with other agents to make sure that the liver doesn't lead to any dysfunction. So that is what they will do. Now, one thing I would say with paracetamol is once you are taking it within these dosing limits and you are above 50 kilos, which I will come on to, if you are above 50 kilos, it's relatively inert. It doesn't really cause too many effects. And if your liver's fine, like I said, there's no real complications from it. One thing that normally happens is that when you are put on paracetamol, a lot of people say if it's not working, that they stop taking it. I would always argue if you are in chronic pain and you are trying to relieve it, then this should be a baseline, because no real pain relief works in the same way as paracetamol. So if you have that and then you are adding other medication on top, it's just only going to facilitate it, and it's called a synergistic effect. Now, the thing that I brought up with 50 kilograms is, so this only used to be prevalent when you were giving it intravenously, so into the vein, is that if you weighed less than 50 kilograms, we would have to lower your dose of paracetamol. But this also applies to oral tablets. So if you weigh less than 50 kilograms, you are probably going to have no more than 2 to 3 grams in 24 hours. And this is just due to the fact that when paracetamol is metabolized, which I am not going to go into, it can lead to a toxic metabolite called, this is testing me now, but NAPQI. That can then lead to liver dysfunction, and is one of the reasons why paracetamol can cause liver dysfunction, basically, is due to a lack of the ability of the person to remove that toxic metabolite. So paracetamol, as long as you are healthy and you are above 50 kilograms, even if you're below 50 kilograms, you just make sure that you are using it as correctly as you can, then there's no real issue with it. But then this is the one, the group of medication that causes the most concern for me. So you've got them, and they are called NSAIDs. Now, stands for non-steroidal anti-inflammatory drugs. And these are your ibuprofen. I really need to get a big whiteboard because this is absolutely a pain in the backside. So you've got ibuprofen, you have naproxen, you have diclofenac, which is not really used much anymore. You have quite a few other ones, indomethacin, so on and so forth. But these are the most common ones. And the way these work are, Should I go through how they work? Right, I'm going to go through how they work. So there is a membrane. No, I'm trying to make this in the most concise way possible. Yeah, I'm going to go through how they work because then it will then give you greater insight into why they have the reactions that they do. So from these NSAIDs, they inhibit an enzyme called cyclooxygenase. Now, we have two isoforms of this. We have 1 and we have 2. Now, in an ideal world, this one is the one that is increased when we have any inflammation in the body. This one is not so much, it's sort of a background enzyme and it doesn't really raise that much when we have inflammation. However, these medications as a whole, there are more selective ones, but as a whole, they will inhibit both forms of it, which is where most of the side effects come from. So I'm not going to go into the full schematics of going through phospholipase A2, blah, blah, blah. But this molecule anyway, you'll have arachidonic acid, and then that will get cleaved by the COX enzymes. Now, on the one side where you've got COX-1, you will have it where that enzyme produces things such as prostaglandins, and these are what increase the stomach mucosa, and that protects your stomach from any irritation, from any acid. So that is why, and I'll come on to it, why anti-inflammatories can increase the risk of stomach inflammation and stomach bleeds. And then you have, what else do I want to discuss on here with regards to side effects? And then these prostaglandins also affect how you regulate the kidney function with fluid, which is why they can lead to kidney injury. So that's, I just wanted to bring that up so you've got a rough idea. If you look into it more, there is obviously a massive schematic on how NSAIDs work with anti-inflammatories, how corticosteroids work. It's all basically on the same pathway. But now that you can see that when you reduce prostaglandins, you will have a reduction in mucus that's produced in the stomach. So why is that important? So let's say that this is the stomach. You will normally have a barrier of mucus, which is here, and you will have stomach acid in the middle. Now, this stomach acid is highly acidic. It's usually, if you want to look at pH scales, normally about 1 to 3, similar to hydrochloric acid. But basically, if you have all this mucus, I keep saying mucosa, this mucus here protects it from directly interacting with the cells here. So you get, it's a protective barrier. However, if we are not producing this barrier here, so let's say it doesn't produce it from here and it goes down slightly, the acid can directly irritate the lining of the stomach, which leads to gastritis. It can lead to ulcers further down, and that is how we develop stomach bleeds, which is the biggest side effect that comes with non-steroidal anti-inflammatory drugs. And is why we don't really like to prescribe them more than a few weeks at a time, because they are really good in how they work. However, they do come with so many side effects that you just need to be aware of how they work. So normally you will get advised to take a medication such as omeprazole, and these just reduce the amount of, PPIs of the class. These reduce the amount of stomach acid produced. But as you are all aware, all medication comes with side effects. So it's a risk benefit. If the risk of you having a stomach bleed is greater than the risks of maybe having low B12 and low magnesium, then that's probably the best thing to do, especially if it's on a short-term basis, such as 2 to 4 weeks, then I would always go for that. The other risk associated with anti-inflammatories, like I just said then, you have, how am I going to do this? I'm trying to, if you wonder why I'm pausing a lot, it's because for me, obviously it's quite easy because I see it every day, but in terms of how do I get this across without going too far into the physiology and the anatomy is the difficult part. But when you have your kidney, I'll have to hold it like this, I think. Actually, let me just double check that it's in camera before I go on. Yeah, it looks a bit better there. Right. So if you think of your kidneys, you have 2 and they drain both into your bladder and then you urinate out that way. Now, within the kidney, you have little tiny things called nephrons, and these are the functional units of the kidney. So the reason I had to draw attention to that is because I'm going to zoom in on a nephron now. And these are the working components of the kidney. So you'll have something that looks like this, and urine goes that way. Now, the blood comes into this Bowman's capsule here, or the glomerulus. So you'll have an artery come in, it then forms capillaries here to allow blood and a few other things to leak out. And then the artery goes out and then follows the nephron around so we can have a transfer of electrolytes, waste products. But the way in which anti-inflammatories work is that it affects the blood flow that comes in and out of here. And the way it does it is that it reduces the pressure going into the kidney. So if we reduce the pressure going into the kidney, then we can basically starve it of blood flow, and you can develop something called an acute kidney injury, which stands for AKI. And you may see this on any medical documents if you ever go into hospital and you see AKI on your discharge paper, it hopefully says none. But in a lot of patients who take these, you tend to get a lot of AKIs, which is why, again, another reason as to why we do not like prescribing these medications long term, especially if you are over the age of 65. But I would say over the age of 40, I'm seeing more and more patients have these adverse reactions. So, a few things to look out for: any reflux, any reduction in urine output, any blood within your stools, any blood within your urine. All these things will force you to go and get these reviewed. But they're all the tablet forms. So I will come back to a few of these questions after this section now. But when it comes to another way that you can use anti-inflammatories is that we can use the gels. Now, a lot of people don't like using the gels because they feel as though it's not as effective. However, when you look at all the evidence and it comes to, let's say, osteoarthritis, which is basically where you have the most common one is knee osteoarthritis. So you've got the femur coming into the tibia basically, and then you don't have the cartilage there, so then it causes friction, a few other things, and you get inflammation there. If you apply gel to that knee joint, it will work locally and it reduces the risk of having stomach bleeds, kidney issues, and all the other complications that come with anti-inflammatory drugs. And it is considered to be as safe as a placebo in terms of your additional risk. So I would always, if you are stepping up from paracetamol to an anti-inflammatory, I would always opt for topical because it is just more localized and it is the best way forward. So before I go on to the next section, I will have a quick look at some of these questions. So, is it possible for the top painkillers not to work? It is, and I will come on to them later on. Then I get headaches, and my pharmacist says paracetamol. Now, different conversation, but you can have something called medication-induced headaches, where basically you've basically built a dependence and an over reliance on medication. Now, I'm not saying this is you, but it is a possibility, and then you can actually have headaches due to that. If you are using paracetamol for headaches, it's always a good first call. But if that headache becomes more problematic and it turns into more of a migraine, then you are more likely to go on to things such, well, my pen's not working that well. Go on to things such as triptans, so sumatriptan with anti-inflammatories, but that is something that you will look into a bit more with whoever it is that treats you. Get a big whiteboard. Yes, I need one. Wow, is there any supplements to help the pain, or is it always medication? The best thing to do for pain relief, like I've just said then, is physiotherapy, physical exercise, making sure that you are reducing your body weight, making sure your lean mass is higher than your fat mass. All them things will give you greater functionality and reduce the reliance upon a lot of the things that cause pain. I think being sedentary for a large part of the day is the biggest cause of lower back pain, which, if you actually look at the amounts of admissions to hospital and GP appointments, lower back pain is a massive, massive offender. I get lower back pain when sitting down in bed too long or lifting something in an explosive way. So when you think of lower back pain, I was trying to go through this before. So this is a chair, a very, very 2D chair. If you are a person, I need to go and get a new pen actually. Bear with me with this pen because for some reason it's ran out. I've obviously been talking too much with it, but I will still talk whilst I am on my way to get a pen. But I will try to anyway. Ran out of ink on my pen. So I'm trying to find some more. without smashing up the place. Right. I don't know how many people are on. Is there anyone on? How many? 4. Cool. Right, I am back. Hopefully these pens work. Right, so when it comes to why does lower back pain exist in people who are sedentary, obviously it seems counterintuitive because you're not really putting your body through any force. So obviously this is side on. So if I was to sit side on like this, imagine this is a cross section. So if I'm standing up, I'm not going to draw any of the lower body, but if this is the spine, obviously all the force is going down the spine and it is being able to be, how would you put it? The load is spread evenly, because if you actually break down what your spine is like, you will have a vertebrae, which is the bone. And then in between, you will have a disc, and then you'll have another vertebrae. And it's the issue that a lot of people have lower back pain is because this disc here, the way I don't have anything. If I'm trying to, if this is a vertebrae, so this is a bone, that's the disc, and that's the other vertebrae. If I put too much force on that way, it can bulge out this way without any support. And it's when you are loading the spine in incorrect ways that then you also have, obviously, your spinal cord, you will have nerves going down here. So if this bulges out and touches that nerve, that is when you get nerve pain, lower back pain, you feel dullness and ache, and that is when you get a lot of discomfort. So if you then think about it, if you are sitting down, unless you are in perfect posture anyway, this is a seat. If I sit down, most of the time, I will probably curve my spine and then have my legs off here. So my force is going down this way, but my spine's going this way. So you can load up the spine incorrectly. So that is why being sedentary is one of the reasons. When you come to lifting explosively as well, if I were to do a deadlift, so here's again a side on, that's 20 kilo weight. And then here's me. You should be position yourself like this, where your lower back is straight. And then when you are lifting, you can always load through the same way. I've just heard something and I just thought it was, it's not, it's the telly, right? So that is why I would always say, try not to be a sedentary. While okay, we've done this one. What's the next step if it doesn't work? Knowing the follow-up helps avoid getting stuck on a medication that isn't helping. What milestones should I look out for to know if the treatment's working? So this is the thing that I would always say is when people take pain relief, they usually just go for it in the sense that they take it every single day at the same dose. And if you've developed this tolerance or you know how you feel on that medication, then there is no room for you to say whether you are improving. So if you ever look on any medication, actually it will always say in pain relief when required. Or sometimes if your prescriber's not changed the Latin, it'll say PRN, which stands for when required. Now, that literally means when required. So with paracetamol, for example, if you took 1 gram in the morning and then you go, do you know what, I feel like my pain's coming on a bit, you can then take another 1 gram and then the same going forward. However, if you took that 1 gram 4 times a day, every single day, and you started increasing activity, you do not know whether that activity is improving. So really, I would always stick to doing stuff when required, because if you then find out that you only need to use, paracetamol twice a day, you are getting an improvement. Other ways is if you are using chronic pain medication on a long-term basis, then yeah, assess it off the fact that can you do more steps? Can you do more physical activity without any further feelings or being invoked in more pain? And that's how you would use it. Are there complementary therapies like acupuncture? Yes. Again, as a large mass population scale sort of thing, it doesn't really have the greatest evidence based. However, you may be in that anomaly. You may be the person that it works on. Because it doesn't work on a mass level doesn't mean it's not going to work for you. But when it comes to advising therapies, we obviously go off what is the consensus of the larger population. So obviously, you've got to sort out what works for you. Could physical therapy or specific exercises replace these pills? In theory, a lot of pain can be facilitated via physiotherapy. The only thing with physiotherapy is that it is a long process. There is no guarantee, but it is something that I would always advocate for first. But a large majority of patients, as you will, if you are working within healthcare, you will be very familiar with the fact that patients just want it now, which is fair enough because it can affect your quality of life. But in my opinion, the best way to use pain relief is alongside a physiotherapy or physical therapy program, and then try and come off which one first. So let me see. Is my painful inflammatory or mechanical? If it's not inflammatory, some painkillers like ibuprofen might be less effective than other options. Yes, that is a potential, but if it is mechanical, for example, that can also lead to an inflammatory responses, like I just said then. If it's traumatic back pain due to lifting something heavy off the floor, you would have then triggered an inflammatory response. So even though the original origin wouldn't have been inflammatory, the response to that is inflammatory, and that is why prostaglandins. These are the things that so these are very useful in the body, but they also increase. I can't even think how many there are off the top of my head. I think there's like 6 to 8 or even more, but they have different functions, and some of them do increase pain and hyperalgesia, which is why we use it. And that's why, for example, in women who have painful periods and menstrual cycles, we will give them something called mefenemic acid. And that's because prostaglandins are increased in large quantities. So by having an anti-inflammatory, you will then reduce the pain on them. So yes. What is the shortest possible time I should take painkillers, especially opioids? Always the shortest duration. Obviously, a lot of people who've had surgery, you may get discharged on fentanyl as a quick recovery protocol, or you may be discharged more often than not on codeine and paracetamol. I would normally take these for no more than 2 to 4 weeks, and by that point, post-operative pain or the issue at hand should have reduced enough that you shouldn't need pain relief anymore. But again, once you get to 4 weeks and you still feel pain, you need to look into why do you have that pain? Is it because you've had a complication due to surgery, or is it the fact that you just need longer to recover? And that's why health and everything else is individualized. What symptoms mean I should go to the emergency room? Ask about red flags like sudden numbness, weakness, or loss of bladder control. So this is related to lower back pain. So if you've got your pelvis here, spine coming into it, and then obviously you've got your coccyx here, legs go off that way. You have a cluster of nerves essentially around here, and if you have a loss in bladder and loss in bladder tone, you have numbness down these, you have a burning sensation, you have an inability to go to the toilet for a poo, for example, then you could have something called cauda equina or cauda equina, however you want to pronounce the syndrome. And that is an urgent red flag. That is something that we need to get checked out straight away, because it is usually due to nerve compression within the pelvic region. And in terms of treatments, it's usually called decompression. You don't really see that many people for it. We are very aware of the red flags, but you don't really see many people with cauda equina or cauda equina. So you basically get them seen to. It can be decompression, and you need that because obviously you are compressing the nerves in such a way. So who is the best specialist to see for specific injuries? Depends on what has caused your pain. So for example, you can have many causes of pain. So you've got mechanical. Pain is probably, it's a very, very complex thing. So you've got mechanical, you can have cancer. You can then have individual condition related pain. So you can have cardiac, you can have respiratory, and then you can have obviously inflammatory pain. Believe it or not, you can also have emotional pain, which leads to more fibromyalgia. But obviously, if you've got cancer pain, you will go and see an oncologist. If you've got mechanical pain, probably best seeing a physiotherapist. If you've got cardiac pain, you're best seeing the cardiologist, because is it due to a heart attack or is it due to something else? If you've got inflammatory pain, probably best seeing a rheumatologist. Emotional, you can go and see, again, it's all to do with what has been the cause of your pain. Then, but more often than not, it will be due to mechanical, and it's always best, in my opinion, to have some form of physio input because they are underutilized. And in a world where we don't do enough activity, then it's probably more often not going to be the best way for you. What does a successful outcome look like for me? Again, that's all individual. Depends on what is the biggest factor for your quality of life. If you live in pain free is the biggest thing that you want, then that's going to be the biggest marker for your quality of life. If your thing is actually I want to do certain activities, go hiking, but I'm happy with a bit of residual pain, then that is your marker. It's all individual. What is the risk if I delay surgery for 6 months? Depends on what the surgery's for. Obviously, if you're delaying it, then it's not the best. Can my diet affect my inflammatory levels? Ask if certain foods. Yes. So you can have, a lot of people are more aware of this omega 3 to 6 ratio. Now, these are both classed as polyunsaturated fatty acids, which are good for heart health in general. However, when you have this ratio being in the favor of the omega 6 as opposed to omega 3, then you are more predisposed to make inflammatory molecules. However, I do want to say that doesn't mean you are actively inflamed, which gets pushed in the wrong way. So, ideally, you want this ratio to be 3 times higher, give or take, omega 3 to omega 6, because then that puts your body in a state where you are less likely to produce arachidonic acid, which we've seen before is where we can then get the prostaglandins and inflammatory molecules that way. Omega 3 is more anti-inflammatory, but that is probably the best way. Obviously, ways in which you improve your diet anyway, 80-20 with whole foods to ultra-processed foods, and then having all the other basics. But that's probably one way in which you can mark your diet progress. And in terms of other things, I mean, you would never really assess inflammation unless you had a belief that it was going to be due to a rheumatological condition. So then you would get ESR, you would get CRP, if I can write it properly. You can have that omega-3 index 1, but they're all the ones that come when you go to specialist clinics. So yeah, that's the one thing with the diet. So what exercises are safe for me to do right now? Again, because I don't know what level of fitness you are, I don't know what issues that you have, but if it's lower back pain, for example, it would be making sure that you are less sedentary throughout the day. So it could mean just standing up, it could mean walking a few paces every 10 to 15 minutes. But if you are not in extreme lower back pain, it would then be maybe trying to do 5 to 10,000 steps a day. That's a good marker, or it's a good base to start with. And then trying to do yoga and a few other things. Strength training is something that I would do as you develop more into a structured program. And if you've got access to seated machines, then it's reducing the load off your back. It's taking out your core muscles. That means you have to strengthen them individually through other ways, but it's removing the reliance and risk of injury for them. Should I use heat or ice for specific pain? Each has different benefits. Yes, they all do. I mean, with topical therapies like that, so you've got cold, obviously cold plunges now are a big thing. They will just obviously decrease inflammation. And the way they do that is they just shunt the blood away from the site of injury, which then stops it having the immune response that we would normally have. So if you've got an injury within the arm here, it will then, let's say this is the blood vessels in the arm. After cold therapy, they will go that size, and all the blood goes to the central parts of the body, the brain, vital organs, because they are the important parts of the body. So then you are reducing the amount of inflammatory molecules coming to that site of action. When it comes to heat therapy, I would say heat is best used when you have, it's a bit of an awkward one really because they are both inflammatory, but I would say more of a muscle Strain, I obviously go between the two. Straight after a muscle strain, I would normally apply cold, but then I would probably go to heat because then it allows it to relax a bit more, gives it a bit more, the muscle to stop tensing as much and reducing the pain. But again, it's all to do with your individual injuries. Are there any specific shoes that you would recommend? Obviously, if you've got any issues with your plantar fascia, then you want something that's more supportive, where the heel is thicker in comparison to the toe. So if you've got any issues with your feet in terms of plantar fasciitis, you would like your shoe to be heel here, down to your down to your toe, and that's all sponge. So that's easier. But in general, there's a company at the moment called, oh, I can't even think what they're called now. They're called Bioactive or BioMe. Oh, I can't even think. But basically, they are shoes where they have the least amount of padding, so that it's basically resembling you walking barefoot. And the benefit of you walking barefoot is that it is increasing the strength of your feet, allowing you to be more reactive, increasing your balance. So by doing that, you are strengthening the other part of your body, and that's obviously something to bear in mind. Let me have a look. I think there's a couple of people. If anyone's on here, by all means, fire away. So hi if you are on here. I can't see who is because I'm filming from the back camera. So do I need an MRI or X-ray to confirm? MRI or X-ray imaging of lower back pain, if that's what it's relating to, is usually not advised because most people will find a age-related degeneration, and that's what's going to happen. I would probably have age-related degeneration of my spine because of the obviously wear and tear. It happens with everything in life. So unless you are thinking about it being really, really catastrophic in the sense that you've got severe nerve compression, then imaging's not going to really be pushed by any National Health Service because you're not going to act upon it. What are you going to do differently? So is my knee pain actually coming from my hip or vice versa? The one thing that a lot of people need to bear in mind is that your hips, hamstrings, if I can write them, hips, hamstrings, I would say knee, I would say glutes, obviously fancy word for your bum, hips, hamstrings, knee, glutes, and abs, abdominals. All of these are closely related to basically your posture and pain. So if you've got weak glutes, you are then asking your hamstrings to try and kick in. You're asking your abs. Oh yeah, I missed out. Lower back. So if you've got weak glutes, you're asking your lower back to kick in. You're asking your hips to do a bit more, your hamstrings, and your abs as well. So all these are then putting more pressure on the others, and that is why the lower back tends to kick in more than any, in my experience anyway, anecdotally, over all the other ones. But if you've got one of these that are weak, you are basically within this cycle, and they all interlink, in my opinion. So the best way, for example, if you've got tight hips because you sit down all day, like I am doing now, the tight hips are then putting more pressure on your hamstrings, your glutes, and then your lower back with your abs. So when it comes to treating these things, there is a person on YouTube, and I bring him up a few times. He's called Knees Over Toes, and I think his story was that he had knee surgery about, must have been about 5, 6 years ago. But basically, when he had the knee surgery, they said you wouldn't be able to flex his knee more than 15, 20 degrees. It was very limited anyway. But now he is probably classed as the most hypermobile male, especially of his age. I think he's in his 40s as well, or even more. And he's able to do all these things because he went and strengthened all of these muscles, and especially targeted the knee, because when you strengthen everything around the tendons, the fascia, the muscles, then you get hyper mobility around these places, and then you reduce the chance of injury. And that is a big thing. And that is one thing that I always go on about because I missed out a crucial part within strength training. So I would do a lot of strength. But outside of a squat, or how would I put it? Outside of a squat or a run, In terms of other things, I wouldn't be hypermobile, I wouldn't be really strong, so it would just put me at an increased risk of an injury. So what activities make my conditions worse? Again, that is something for you to answer. You have to test it out yourself. If you are finding that a squat is affecting your knee, then you need to look at what part of your knee is being affected. If it's behind the back of the knee, which is the most common part, you then need to work out how can I then strengthen all the other accessory muscles around the knee, around the glutes, abdomen, all these other things to then improve that. And it does come up with some really good results. It does seem counterintuitive at the beginning. I'm not disputing that, but that's when you get the most results. Is my pain coming from the bone, muscle, or nerves? Again, depends on the injury. So if you've done a bicep curl and you feel near enough instant pain when you are lowering it down, there's a good chance you've strained the muscle. If it comes from you basically not doing too much, you get numbness within the lower part of the leg up to the back of the knee, then there's a good chance that's sciatic, which is nerve pain. It's all individual to you. Does painkillers lead to cancer? I mean, technically, most things will lead to cancer, I'm not going to lie. And most people will probably develop some form of cancer if they live long enough. In terms of, does a painkiller specifically lead to cancer? Not that I know of. There's probably going to be some literature somewhere to say that paracetamol can increase this risk, but in general, not really that I can think of. I wouldn't be thinking if I started a patient on ibuprofen that there's a good chance you're going to have cancer in the future. But the biggest issue with painkillers are, like I said, if you put anything on long term, the complications that I've went through earlier, if you're on them for a longer duration of time, you've got a higher chance of them leading to fruition in that person. So always do it for the lowest amount of time that you can, and always take the lowest effective dose of medication. That is individual. For me, if I needed to have pain relief, I may get away with 2 grams of paracetamol a day, and that's the lowest I can go to. Someone else could maybe go to 1 gram each day, and it's better for them to go to the lowest dose that still provides benefit for them. When pain meds don't work, what's the next step, or is there? There are other steps. There are nerve blocks, so you can have surgery where you can get infusions of nerve blocks. There are obviously surgery itself to remove certain parts, but it is a very complex access. You can have something called phantom pain syndrome, which is where phantom limb syndrome, where someone who's had an amputated leg can still feel leg pain even though the leg's not there, because obviously they've got a relationship between the brain axis. Hello to Jay Rimmer. So what if it's something like a car crash that requires long-term or permanent pain meds at high dose? Is this recommended, or should something be done, or can anything be done? If you've got severe chronic pain due to trauma in that sense, you can always do stuff. Obviously, everything I've said in terms of your diet and exercise, that will always increase the chances of you having a good outcome. But at the end of the day, the way in which the nociceptors, which are the pain receptors, communicate with the brain, sometimes it is just a dysregulated pathway in some patients, and they need to be on long-term pain relief. The way that we combat it are by, definitely not medical advice. None of this is medical advice, obviously. But if they need to be on long-term pain relief, how do we make sure that it is as safe as possible for them? We get their bloods checked at least every 12 months, depending on their age, making sure that we cover the liver and kidney, because that's where most medication is metabolized and removed from the body. And then we just keep having reviews with them, making sure that there are no signs and symptoms going unmissed, and making sure that they, as a patient, are aware of any risks. So have they had any blood within the stools or wee, to make sure that there's no stomach bleeds, make sure that they are not having any cognitive impairments due to high doses of opioids, for example. These are just all the way that we can manage someone as best, in the best way possible, really. When I got stitches, they gave me a needle and I couldn't feel anything. Can that be given on a permanent basis for medication resistance for pain if it's untreated? So when you got stitches, there's a good chance that you were given an injection of lidocaine. Lidocaine blocks the sodium channels, which stops the nerve conduction of pain signals from that point. So it will work within a local way. How do you give that on a long-term basis? Now, there are infusions of anesthetics when you are in severe pain. So these are called like rectus sheath, where they basically infuse it around the abdomen, basically. But in terms of long term, very few people would have access to that long term. And that's just because it's obviously a very time intensive procedure. There's always risks with every medication. And in terms of evidence, I don't think it will have a big body of evidence to go on a long term basis. Can you have a mini heart attack without knowing it? Yes. Many patients have mini heart attacks. But normally, if you go for a blood test and an ECG, even 7 days after it, you can basically tell whether someone's had a previous heart attack before. What are you having for dinner tonight? I'm not too sure, actually. I'm not too sure. So, can these pain medications affect B12 levels? Some pain medications can, like pregabalin for nerve pain. In terms of these common ones, they don't tend to have a relationship with B12 to the extent that we would be advising patients to be aware of it. But whilst I'm here now and I've got another 10 minutes before I have to leave because I've got to go shopping, I'm going to go on to the next class of medication, or the next two classes, so weak opioids and then strong opioids, because these are the ones that cause the highest amount of addiction. These are the ones where I feel people get stuck on for a long time. They always request it and it leads to the worst outcomes. So I will go on to them because it's a bit awkward, really, because a patient will phone the surgery and say, I need this. And then they'll act as if they know more about the medication, which they don't. And then at the end of the day, it's my name on a prescription. So, right, let's go on to it. So if the pain relief in terms of paracetamol and anti-inflammatories have not worked, you will go on to, usually, I'm missing out nerve agents in this because they would be neuropathic agents, are different ones. But you'll go into weak opioids. The main ones, you have codeine and you will have tramadol. Now, the way in which these work, so codeine, when you give codeine to someone, it's not in its active form. It needs to go to the liver. And then from the liver, it is metabolized into morphine, essentially. So, needless to say, if you do not have the enzyme, which is the processing, the process, basically, I'm just going to simplify it to process. If you do not have the process in the liver to convert it to morphine, then codeine will not work for you. You also have a group of patients who are called hyper-responders, where they have too much of the processing capabilities within the liver to convert to morphine. So then they have a greater response. They have more side effects. The thing that you need to look at, it's called CYP2D6, I believe. I haven't looked at it for many years, but CYP2D6, and you get morphine. Now, the maximum dose, again, all this is not medical information before you take this. The maximum dose of morphine each day, depending on your circumstances, is 240 milligrams. When that gets converted to morphine, that is give or take 10% into morphine. So for a maximum codeine dose, you will get 24 milligrams of morphine a day. For tramadol, it works slightly differently. So it is eventually converted to morphine. So it will go to morphine. But it also has an added action by it works very similar to an antidepressant. It works on the serotonin pathway, which then gives it basically more of an addictive property, but also it tends to be a bit greater when it comes to pain relief with tramadol. But the issue is when we prescribe tramadol for a lot of patients, it becomes highly addictive, and trying to get patients off tramadol is a very, very difficult task. But the maximum dose, if you were under prescribing, is 400 milligrams a day. Again, follows the 10% rule. So you will get 40 milligrams of morphine. So these eventually get converted to morphine. One thing you will see with a lot of patients is that they will take codeine with tramadol, which makes absolutely no sense because they both go to morphine, and because one's competing in the liver and both of them are metabolized that way, it just makes it a higher risk for side effects. And if you need both of these, then you may as well have the discussion to go to the stronger opioids of morphine in its original form, essentially. But with these, again, the biggest risk is that they are highly addictive. And with all opioids, they can do something called respiratory depression, which is basically the biggest reason as to why a lot of people have a lot of fatal outcomes when it comes to opioids. So some people may be aware, if you've got a severe respiratory condition where you feel breathless all the time and you have trouble getting breath within your lungs, we can give people morphine. And when we give morphine, it basically slows down. So it slows down your rate of breathing. So it seems counterintuitive, doesn't it? So let's say a lot of patients who are palliative, so end of life, struggling to get any air, we give them something that then slows their breathing down. But the thinking behind it is, instead of you going, it allows you to slow it down so each breath is more full. So gives you more oxygen, gives you a greater response. So when you are thinking about, we use that for palliative patients. When you have high doses, which is what normally happens with when you see a lot of people sadly overdose on illegal drugs, or you see a lot of celebrities who then have fatal outcomes, it's because when you have increased opioids, you are decreasing the rate of breathing more, which is respiratory depression, and then they're just not basically getting enough oxygen in the body, not able to function. And that is where a lot of the risks come from. So when you pair that up with the fact that they are highly addictive, they make you feel drowsy, they make you lose a lot of cognition when you are taking them. It just makes a recipe for disaster. Now, if you are then not controlled on either one of those drugs, you will go to the strong, which are opioids. Now, in the NHS, we've tried to reduce these greatly because, as you probably are aware, or you can probably work out for yourself, that the amount of poor outcomes from these medications and the complications that arise, obviously death being one of them, you have numerous hospital admissions, you have the addiction, other things that it feeds into is so high that we don't want patients on these for too long. And if they are, we want them on the lowest dose possible. But the ones that are common, so you've got morphine, you've got buprenorphine, and you have fentanyl. These are the most common ones. Obviously, there are more, like I've said, there are tapentadol, there are pethidine, you can go on. But these are the most common. And the biggest thing is they all slightly work on different receptors. So let's pick morphine. They work on the mu opioid receptor. The reason I'm telling you this is if you were to have, how would I put it? Someone was saying before, if you had like lower back pain, for example, yes, these would work. However, you wouldn't get the same response because the pain is usually inflammatory in origin due to it being a pulled muscle, whatever it is. So you wouldn't get the same response. So they work on that pathway, goes through to the brain, basically cuts off that pathway. So they become very, very, very powerful. And side effects, I've just went through them all before, and the risks of them. The idea with these is that you will have eventually a baseline dose, and then you will have a when needed dose. So you will pick something at your baseline, and then if someone requires more by using it when needed, you should ideally calculate that with the baseline dose and increase it or decrease it depending on their needs at the time. It's obviously a very, very fine balancing act, and is never ever an easy conversation. It is the hardest medical consultation that you will ever have, is discussing opioids with the patients, especially if they are highly addicted to them, because it just becomes a conflict, not a conflict of interest, but it just becomes a very, very complex procedure. Now, there are medications that I have not included, which are also highly addictive in the whole thing. So we have got nerve agents, for example. So you've got your pregabalin, you've got amitriptyline, you've got duloxetine, Obviously, a lot of these either started off as anti-epileptics, antidepressants. They obviously work very well. They work within chemical balance in terms of nerve pain. The issues are, again, they can become quite addictive. If you are on any other mental health medication, it is then increasing something called serotonin syndrome, which a lot of people aren't aware of. But basically, if you increase serotonin to large amounts, again, it's all individualized. Some people can have a very, very low response to serotonin or low threshold to serotonin. Hello to anyone who's joined. And basically, it leads to you having either this dysfunctional process where you have high agitation, high irritability. You can have muscle rigidity, if I can speak. You can lead to a different capacity to handle body temperature, and eventually you can lead to seizures and obviously further down the line complications from that. So I'm well aware of serotonin syndrome, get told about it at every appointment. It's a very, very serious thing, but because a lot of patients now are on a lot of medication that can cause serotonin syndrome, it's a very tricky thing. From an ethical point of view, from my point of view, is most patients that are started, so amitriptyline, let's pick it. Usually it's not licensed, meaning that it doesn't actually have a use in nerve pain where it's covered legally. We just do it because it obviously had a lot of evidence. Now, if you wanted to add this at 10 milligrams at night, usually in a lot of patients that I deal with, they will be on, for example, mirtazapine. They may also be on citalopram at the same time. So then you are adding in this other medication, which is more of a non-selective blocker of serotonin onto these two. The risk goes through the roof. And then given the fact that a normal patient who has these types of medication is more receptive to mood changes, being irritable or agitated, it then makes it even harder to see when that medication is actually having a side effect or whether it's safe or not. Now, I will just go through a few of these questions and then I will have to leave in literally 1 minute. So, if you have a mini heart attack without knowing, what does that mean and when would you know? You would only know if you go and get bloods in an ECG. And usually troponins will show up so long after a heart attack. In terms of what does that mean, it shows that you are having a lack of oxygen to the heart at some point, and it should always be something that you go and get addressed. So definitely worth getting checked for that one. When it comes to if a patient sees you and asks for tramadol and Google symptoms just to lie, obviously at the end of the day, it's all up to us when we start pain relief. I wouldn't personally start tramadol in many patients, to be honest. The only time I would ever consider starting tramadol is if they've had a full examination from a pain clinic and they've had every other option explored, because I feel like it is one of them medications that's very hard to come off. If a patient becomes addicted, how do you get them off? With these types of medications, because they work within the brain, usually it is a slow process. You'll do it over maybe 4 to 8 weeks. You can't stop it abruptly, and that is the best way forward. Sadly, there is no guide for us to follow and say this is what you should feel at these dates. It is basically a clinical judgment, and we have to go through it and hope that the patient tolerates it well. So, can one person take a dose that works for them? Of course. Oh, but the other person takes the same dose and they OD. Not, but an overdose is a bit different. An overdose is where you will have a toxic reaction to it. So you may have side effects to something where it's a listed side effect, but in terms of being toxic to the body and being a major complication is very rare when you are using it within the specified dosing limits. So that's a big thing there. What is the most powerful pain medication ever prescribed that is no longer used? Ooh. I think the most powerful at the moment is probably fentanyl. In terms of potency, it's 100 times more potent than morphine. Obviously, we dose that accordingly, but if you have the same amount, it is just very, very powerful. And that's why a lot of people in America are having big crises with it. Last one, dexamphetamine and paroxetine, high chance of serotonin, yes. Would you prefer I spam you with questions? Do you think I'm flooding the chat? No, I think obviously having questions is always a good thing. And I think it leads me nicely to 6 o'clock, which is when I said I would be finishing this live stream. Otherwise, someone will be going shopping without me, and they can probably hear me now because they're in the hall. So thank you very much for watching. I will probably do another live stream when something like this pops up again, where I just feel like a lot of people need to be aware of the risks of something, and also how we manage it going forward. Hello, we have Yoko. So thanks for joining. Sadly, I am leaving, but I am going to leave this one up on the channel, so you can by all means go and have a look at it, because it will be available on demand if it is something that you want to go to and just have a quick look at the main classes of pain medication that we went through, and why it is essential that you are safely being prescribed these medications, but also using other things alongside it to make sure that you are at great, probably going to have the greatest outcome anyway. But yeah, thanks very much for watching. I'm going to go shopping, and I will probably see you at some point this week. Thank you. This is the hardest part.